Well, my name is Alieke Scholten. I am a district nurse from the Netherlands, Buurtzorg. And since 5 years a happy district nurse because I love to work with this model. And that's why I'm here to present.
I'm Gertje van Roessel. Used to be a district nurse and now work as a coach for Buurtzorg from the beginning in 2007.
So in 6 minutes we will line out the main principles underlying this Buurtzorg model. And our slogan for today is humanity above bureaucracy. And of course everybody likes this slogan, but how do you make it real? That's what we would try to explain. Shortly, a very short quick scan. Buurtzorg started in 2007. 1 team, 4 nurses, and now we are with 800 teams, independent, and more than 9,000 nurses, 2 CEOs, no managers, 15 coaches, and about 45 in the back office supporting all the teams. So 70,000 patients a year and a turnover of 280 million. Euros. I don't know how many pounds there are. That's the quick scan. Well, as in England, in Holland, we felt transition was needed. Our clients were not happy because they saw too many faces, too many nurses, not well educated people at home. The nurses were lost their autonomy to do the jobs well, and costs are increasing. So that's why the time was right for a revolution in home care in Holland. 4 principles. 1 is the content of care, the starting point of organization. 2nd, independent self-organization teams. 3rd, support instead of managing. And 4th, organizing follows changing context. About the 2nd one, the starting point is the content of care, which means that the whole organization of Buurtzorg is built around this content of care. If something is not fitting the benefit of the care, it's not in the organization, it's wiped out, you can say. Buurtzorg gives the professional a lot of motion space to do what's needed. Work with well-trained personnel. Everybody is a registered nurse. The organization gives a lot of trust to the teams to work out what you think is good nursing care. And we are very good supported by our Buurtzorg web, which is on the intranet. We can use, well, I will tell it later on because that's not for now. Sorry. The 2nd principle is that we work with self-organizing teams, which means that a lot of tasks usually done by managers are done by the team, like your shift and routes planning, the job interviews if you want a new colleague, of course the whole nursing process from start to end, assessment to exit. The housing, how to organize your own office, the PR, the budgeting, the education, it's all a responsibility of the team. And it's interesting to get these responsibilities because then you can find the best solutions for all the different items, and you cannot say, okay, it's a problem of them and I can complain and nothing changes, because you are the owner of your own solution. It's a good system, I think. Yeah, going on, okay. I still have time, yeah, good. The 3rd principle is that Buurtzorg chooses to facilitate and support teams rather than manage them. And I, as a nurse, really feel that's true. I feel supported by the back office. They're very helpful. Need to prepare good care with my team. It's available, and if it's not, I can ask for it, and they will help me to find it. So It's great. And I have a coach. All the teams have coaches. We can ask for help, and it's again very supportive. She knows about other teams, solutions in other teams, and if there is a problem in my team, I can ask for Gertje, for example, and say, "Hey, do you know in other teams what was their way of find a solution?" It's very helpful to have a coach. About the back office, I mentioned. Also, all the things you need to learn for your education. A lot of it we can find on our Buurtzorg web with the e-learning environment. So we can be up to date very easy. It's a good system again. The fourth and last principle. The title is a bit difficult, but organizing follows changing context. Buurtzorg choose to be an organization who is organizing all the time, being aware of the context, who is changing all the time, is different in the north of Holland or in the south of Holland. So not so much fixed rules, not so much fixed meetings, whatever. Being free, the whole organization to adapt to the situation. Yeah, and so being comfortable with a diversity of teams. So there's not much fear in this way of organizing home care, which we believe is a good way. And we have nice figures of happy clients and happy nurses in Holland. So.
Okay, I'm Mel Stewart. I'm the lead school nurse from Your Healthcare, which is based in Kingston.
And I'm Myra Ford. I'm one of the board leads, but I also, when I do these sort of things, actually say I'm a district nurse by background as well. What we want to do is just take you a little bit about our journey. And when we were talking to the guys from Holland earlier on, it says how we've done some Buurtzorg principles, but actually we both started our journeys about the same time. So by default, we've been implementing some Buurtzorg principles in our journey. Looking around the room, I can see a lot of community colleagues in the room. And we started our journey back in 2006 when there was the decision to separate provision from PCTs of community services. It then took us 3 years to exit the NHS, delivering government policy, but we did do it. And it was a group of nurses and therapists who set themselves up to run their own company as a social enterprise. We were established in 2010, and we were the first social enterprise in London, the second nationally, and we've been joined later by Bromley, who you've heard a lot from already today. But equally, in what we're celebrating in 2013, we took receipt of quite a lot of the local authority services, which included residential homes, daycare provision, and reablement, which became part of our integrated health and social care model.
So looking at our shared values and what it is that we feel makes our organisation the way it is, it's all about adding social value. And I think it's about the way we conduct our business. So I think it's the relationships we form. And these relationships are amongst ourselves, so with our own staff, but also with partner agencies, and most importantly, with the service users and the community that we work with. And we feel it is this model that frees up time, which means that we can deliver excellent services.
I'm not going to spend too much time on this, but a lot of you will recognise this. This is where we come from, with a long history of public service delivery. But it's where it starts to mash over what we're about as a social value ethos and some of the principles that we own up to. So it's important that we earn income. It's important that we deliver a surplus, because all of that is about growing and developing those services. It's about putting as much of the money that we make in our business and put it in the front line, because that's where the money needs to be. So we're proud to say that 87% of our resources in frontline services, all of it is being delivered through our teams.
So just thinking about the surplus resources going back, I mean, with 86% in the front line. For someone like me, I work on the front line. I know what my budget is. I know what the expectation is from the Commissioner. I know the staff I've got available and the service that the service users want. But it really is at that stage, it's up to me and my team how we deliver our services. If someone leaves the organisation, it's up to us what we do with that money. Whether we want to look at an IT solution, whether we want to get more staff or more grades. So it's quite an empowering way to work. I also think that we do a lot of investing in our staff. I think what we do is when we went into our journey, we looked at what the services were that we had at that time, and we made sure that our staff were trained to deliver those services. But what I think we've got really good at in the last few years is looking at what could services be in the future and making sure that we're trying to work with our staff now to train them up and invest in them and to give them the development so that they can meet the sort of ongoing needs that we have. We also, we do share what we learn, and we're also working with other social enterprises and other organisations that are thinking about looking at a mutual model in health. And as we've mentioned, it was staff innovation that led to the coordinated health and social care teams coming together. And on them coming together, we've actually managed that we don't actually have waiting lists for either service now. So to us, it's all about putting the needs back around the client. In particular, health and social care coming together, we have a single point of referral. So if anyone needs to come onto any of the books, it just is one way of doing that. And then the assessments are done to see actually what it is that that patient needs. And what we found, if patients don't particularly care what we label their needs as being. So as professionals, we might say, well, actually that's health, but that's social care. The patient doesn't care particularly. What they want is a package of care that works around them with minimal interruptions to their day as they're trying to get on with their lives. We're working at training generic workers that can go into patients' homes and they can actually spend more time with these patients because what they can do is give them more of the services that they need. And our generic workers are very well supported with specialists within the community. But it means for the patients and the workers, they can start to actually build a really nice relationship together. I think one of the other things that we'd like to mention that we're very, very proud of is we're currently doing a pilot with the London Ambulance Service. And if someone phones up and it's a 999 call and it's a category C, then an advanced nurse practitioner will go with the paramedic to the patient's house. Once they're at the patient's house, they will do a full assessment of what the patient's needs are at that time, and the nurse practitioner and the paramedic together will treat the patient at home if it is safe to do so and if it is appropriate. Having this model as well means that if a client's seen and we actually think, well, actually you could do with being seen in a few hours' time or in a few days, or what you actually need is some social care or some health care, we can refer them straight into our system. And what we found currently is 70% of patients have actually been managed to be treated at home. I think one of the most exciting things about working on the front line, it's having, I know when we listened to one of the talks earlier, it was talking about permission to make change, and I really feel as an organisation that we have that permission to make the decisions that matter. We have a lot of informal conversations, and that tends to be how we make our decisions on services and where we're going. We don't tend to sit around and have long meetings where lots and lots of people are sitting around the table discussing the same things over and over again. When we have the permission to make changes, we have also got the permission to make mistakes. And I think as an organisation, we're very much a learning organisation and culture. We know that staff are happy, and we know that 96% of our staff are very, very proud of the services they deliver. And a lot of our staff are also service users as well. I think for me, when I think about what actually makes the difference, I feel that I can do things simply because it is the right thing to do, and I feel that I work in an organisation that will support me in that.
So, how do we know it's working? We've got a strong culture of MDT working, which is expanding to include third sector colleagues as well, because there's a lot that we can do by working with some third sector colleagues to support people in the home. People don't aspire to have long stays in hospital, to be admitted to a residential care home setting or to a nursing home. So it's all about what services can we mobilise to support people in the home. We've looked at our skill mix and we've used our skill mix to go into GP cluster models. So it's about having the right workforce to deploy around those GP communities. As Mel said, decision making is faster. It's done at the team, it's done lower levels. It's what you need, your resources there for you to make that fast decision making. We're looking at our hybrid health and social care support worker roles to prevent that duplication. There is nothing worse than when you have a steady stream of professionals through your home. It's about having the right person at the right time to deliver the care. And equally, it's about increasing our role in admission prevention. And an example at the bottom is something that was on a live Twitter feed, which one of our rapid response nurses said to me, which was, my mum had a visit from rapid response today, and she did more in one day than the GP had taken for the past year. And that's not to say the GP wasn't doing its best, but it's about making sure that our staff have got the right resources that they can pull in together to support those people in the home. So what's the evidence? The big red in the middle is what we all know. We live in very challenging financial times, and in real terms there's been a 4.5% reduction in NHS and social care funding. But as an organisation, we've had 20% growth over the 4 years that we've been in operation. That equates to 2% increase in service provision, and we've got good sickness records at 4%. That's sitting slightly below the norm at the moment. 90% of the resources, as we said, are in front line, and Mel's already mentioned that 96% of our staff are proud of the services they deliver, and that's also played out in what we see in our patient surveys as well, where 97% of those would recommend our services for treatment. We've actually grown our business through a lot of our traditional commissioner routes, but we're also working how we can work wider. So we're working other people. So we're working with some acute foundation trusts at the moment about where they're looking to be part of the mutual model in health. What does it mean if I was a big foundation trust and became a mutual operating in the health sector? And finally, as we finish, thank you again for your attention and any questions.
Thank you. Okay, hello everyone. My name's Farah and I'm the lead speech and language therapist from the Hounslow Community Learning Disability team. I'm going to tell you a little bit about the dysphagia service in Hounslow and the changes we've made to it. So just a quick sort of introduction for anyone who hasn't got a clinical background to what dysphagia is. Dysphagia describes quite broadly any problem with eating, drinking or swallowing. And in the learning disability population particularly, it accounts for the largest cause of death by quite a majority. And really the problem that we were having in Hounslow is we were seeing quite a dramatic increase in presentations of dysphagia from in all different sort of levels, and referrals to the community learning disability team. This increase was generated in particular from younger adults, so people who are coming through transition, coming from the special schools with profound learning disabilities, but also older adults, so adults with dementia in particular. We only had one team member trained in dysphagia assessment and management. That was me, so we were a uni-professional dysphagia service. This created obvious risk because for waiting times really, if I was on holiday or absent, there was an inevitable wait. We didn't have any additional resource possible, so it wasn't possible to invest any more in the team to recruit anybody else. What we did have in the team was a big multidisciplinary team with lots of other professionals who didn't have any additional dysphagia training, but they did know the service users quite often that we were working with. Another problem we had was referrals were often being made late, so it might, because of the limited dysphagia knowledge that people who support people with learning disabilities might have, they weren't always recognising signs of dysphagia until things had progressed quite far, and maybe we were at a point where it was going to be very difficult to intervene. So there was a lot of preventable illness and possibly even preventable deaths. So we looked, when we were looking at how we would solve this, we looked to the acute sector. So we had an awareness that in the acute sector things were happening slightly differently, and dysphagia training was being disseminated to the multidisciplinary team, but particularly nurses. So they were able to do dysphagia assessment over the weekends when speech therapy wasn't available. Mostly to meet targets, because there was guidance that said dysphagia assessment has to be done within 24 hours, for example, post-stroke. We weren't aware that this was happening in other learning disability services. So we liaised with the acute services and looked at the model that they were using to train their staff, and we adapted it to fit our client group. And we developed a training package which we think could be transferred to lots of other community settings. That's a face-to-face learning package. We designed it basically using a framework called the Interprofessional Dysphagia Framework, the IDF. So this is a comprehensive framework of competence which really outlines 4 different levels of competence in dysphagia management: assistant, foundation, specialist and consultant. And it was developed by a steering group that included not just speech and language therapy, but the Royal College of Nursing, physicians, dietetics. So it was very multidisciplinary in its creation. And it informs strategies for developing the skills, knowledge and ability of the whole multidisciplinary team to not just identify swallowing problems, but also to assess them and to manage them. So the framework in practice: well, we trained 4 staff members. That was 2 learning disability nurses, a dietitian and another speech and language therapist, and they were all trained to foundation level. There was a time commitment of 5 complete training days and then a minimum of 30 hours of observation and supervised practice. So we had 5 full days of theory and learning, and then quite a lot of time additionally where they would firstly observe me and then I would observe them, moving towards working independently. We allocated the cases where possible to clinicians who were already working with that patient. So we did acknowledge that those staff didn't necessarily have any additional capacity, but if they were already working with that patient for a different health need, which they often are, because dysphagia doesn't happen in isolation, it usually co-occurs with lots of other medical problems. So we would try and match those service users with clinicians who were already working them to make the whole process more seamless for them. What this has also meant in increasing the skills of those clinicians is that they're able to identify the signs of dysphagia a lot earlier and make referrals to the dysphagia service sooner, which means that those service users can join the dysphagia care pathway earlier and hopefully have much better health outcomes. Thinking a little bit about the future and where we plan to take it, 1 staff member already has requested to train up to the next level of practitioner, which is specialist. The clinicians will be running dysphagia clinics, so these will be monthly, and as well as that they will be taking on a small caseload of people they were already working with. We need to explore how we're going to integrate these additional responsibilities into their time, because like I said, we recognise that they didn't necessarily have additional capacity to take on these responsibilities, so we need to think how we'll be able to do that seamlessly. We would eventually like a hierarchy of skills within the team. So rather than just having a few staff members trained in dysphagia and the rest of the team still with no formal training, what we would eventually like is a staggered approach where everybody in the team will have some level of training, sort of from awareness level going up to a much more specialist level. We're going to audit the project to audit the efficacy and see if we've managed to reduce waiting times, see if we've impacted the professionals' time, so if their caseload and time has been adversely affected. And also we'd like to audit hospital admissions and health outcomes of the people that we work with and see if we've managed to prevent any of those. Finally, we'll do reliability checks as well. So all those clinicians will have named supervisors, so I'll still be working with them closely and supervising, but we'll do reliability checks as well, where from time to time we will both do independent dysphagia assessments to ensure that we'll both get the same results. And that's it.